thank you so much for joining this session. Although it's a little bit late, but just before a nice dinner, we would like to enjoy discussing a lot of nice topics with contemporary TAVI. So my name is Yohei Ono, interventional cardiologist at Tokai University Hospital, and I'm really honored to co-chair this session with Kentaro. No need for introduction. And we have a really nice, distinguished panel, experts from all around Asian Pacific. So Jimmy, thank you so much for joining. Dr. Swas, thank you so much for coming. Kent, thank you. Please enjoy this discussion, and we will keep you discuss a lot about these topics. Okay, so without delay, I would like to introduce our first speaker. So first, we would like to start with 1 year. Actually, last year in the ACC, as you know, a SMART trial has published and discussed a lot over the years. We know about the data, but we want to know how did this impact everyone's clinical practice. So why not start with the panel discussion? Dr. Posas, can you share your thoughts about this trial and your influence to your clinical practice?
Yeah, one of the issues really is that the definition of a small annuli is 430 millimeter square. And that is the average annular size that we see in the Philippines. We are seeing annular areas of 360 plus for females. So the question is really, is the data truly applicable to small annuli in Asians? And can we achieve the same outcomes given the smaller sizes? I don't know if this is the same in every Asian country that is applying this therapy, but it certainly gives us an idea, because we've been dealing with small annuli. It gives us the idea that what you see in a child, it's basically what we've been achieving in basically on a regular basis.
Yeah, so obviously the small annulus we cannot disconnect with the body size, body surface area, which defines the incidence of the ppm and so on. So Ken, do you have any insight on this?
I think this is actually quite an important point, because the size that we have, based on SMART trial, is based on the Caucasian population. If we are talking about in Asians, from some of the data, especially from the Ocean Registry, it seems like 430 is covering maybe more than half of the cases. So this is might not be valid. But then, are we able to derive maybe a body surface area index or BMI index type value for us? That is something that we need to do to get a next step, I think.
Mm-hmm. Yeah, thanks for your insightful comment. So, Jimmy, as you are a cardiac surgeon, how would you approach to the patients who has small aortic annuli?
So previously, if we have a small aortic annuli, then surgically, I think contemporary surgery will include doing a more extensive surgery of doing root enlargement and putting a bigger valve in, because we are always worried about patient-prosthesis mismatch. But with so I think what SMART trial has done is that it's contributed new information to this field of aortic valve stenosis, and now transcatheter heart valve becomes a possibility for consideration of this group of patients. So we know that, of course, the gradient is not the whole story. It becomes an option, a very important added option that now we have, as long as our job is really to prioritize what is the most important factor for any particular patient. Is it coronary access, or is it gradient, or is it future TAF and TAF? Mm-hmm. So our job is to prioritize these for our patient, every individualized treatment, and SMART trial comes into consideration in a big way.
Mm-hmm. Yeah, thanks so much. So Barbir, so how did this result impact your clinical practice in your specific patients, in your region?
So in our country, if you look at the small annuli, they correspond to about 50% of all our patients. And that's a huge number. And so we were actually facing these problems even before the SMART trial came out. So with the SMART trial, we know that many patients in India are younger and they don't want a surgery to be done. So we are forced to do many patients who are even less than 65 years of age. And when you're talking of less than 65 with a small annulus, you have to keep this in mind that you want a valve which gives you better hemodynamics.
Sure. Which will translate to the future durability of the valve, performance. We'll get back to you, Man and Carl, after this session. So, Dr. Posa, do you have the presentation of your nice data regarding the long-term follow-up of your patients?
So, good evening. So nice to see a good audience at this time of the night with Tokyo becoming and the night calling. But thank you for inviting me to speak here. This is TAVI and small annuli. I'm a proctor for Medtronic. But what is the real definition of a small annuli? Annular area of less than 400 to 430 millimeters of mercury, mean diameter of less than 20, or annulus that can only accommodate a prosthetic valve size of less than 21. We looked at our data on 300 Filipino patients, and we saw quite interesting information. One is that the annular area of the males is pretty big, but the annular area of the females was an average of 363.35, with 69% of 69 or 70% of patients being smaller than 400 millimeters. So it's a real significant issue for females, and that is the same thing for the LVOT. Coronary arteries do not seem to be a problem. I wanted to present a case, a female, 83-year-old female, obese, who came in with congestive heart failure. And one can see that the perimeter is 63, the area is 291.3, with a rather small sinus of Valsalva. Valve was tight, Vmax of 4.08. Access vessels were pretty good, so treatment plan was to do fully PERC, BAV with contrast infusion to assess risk of coronary, Evolut 23, and coronary artery protection plus temporary pacemaker. And this is basically the procedure. We put a balloon, injected, we got uncomfortable with the left main and decided to protect it, and put a wire down the LAD. This is the valve implant, went in very easily, properly placed. The valve is well expanded, no significant issues with the coronary, so we removed everything else, and the patient did well. This is the post-hemodynamic showing basically no gradient. And this is the 3-year follow-up of this patient showing the sustained AVA at 2, mean gradients that are 1.6, and the mean gradients of 5.4, very low. So this is basically what we are getting with native valves when we put 23 millimeter Evolutes. This is the second case, Tabinsab, 77-year-old female, known CAD, post-CABG, IMA to LAD and AVR in 2014, 19 millimeter valve, CE peri mount, hypertensive, CKD, non-diabetic, non-smoker with no family history. Once again, perimeter of 53, area of 225, with a fairly capacious sinusal valsalva. The echo showed that the valve was tight, mode of failure was basically stenosis. But more importantly, when we looked at the CT scan, we looked at the surgeons had actually tilted the valve towards the right coronary artery. I assume that is to protect the left main during the procedure. So the vascular access vessels were relatively small. The treatment plan then was to put a temporary pacer, protect the brain, a coronary angiogram and revascularization of a left main lesion, pre-TAVR bioprosthetic valve ring fracture, and an Evolut R23 inside. So this is the left main. We put a crossover stent from the left main to the circumflex. And that is the final result. And on the right-hand side, you can see the Sentinel devices as cerebral protection. Then we went for the valve fracture using a true balloon, 20 millimeters. We managed to fracture that valve. Following that, then we noticed that the right coronary artery had a perfusion issue, so we put a catheter in a wire into the right coronary artery and proceeded with the deployment of the valve. As you can see, the valve is properly positioned, yet the flow in the right coronary artery is sluggish. So we decided to implant that stent into the ostium of the right coronary artery and achieved a pretty good result with the coronary. And then did a rotational frame, which is our usual way of assessing valve expansion, and noticed that the valve is properly expanded. The post-op hemodynamics basically showed no gradient, and the 1-year follow-up shows that the AVA remains pretty decent with reasonable Vmaxes and a mean gradient less than 20. The patient is functionally okay. So we looked at the data, looked at the high-risk trials comparing surgical valves and core valve, and showed that we can achieve bigger AVAs with the core valve and lower mean gradients compared to surgery. Importantly, we get less ppm with the TAVR device, and that translates into lower mortality and lower and better valve durability. This is our system of care showing a Swiss knife with the center in the middle of the procedure. And we have good surgical services who can do annular enlargement. So anytime we get one of these patients, we always talk about annular enlargement procedure. So in conclusion, small annuli represent significant procedural and lifetime management challenges applicable to both SAVR and TAVR. This is particularly applicable to Asian females and the elderly and impacts lifetime management and coronary access. It also has a significant impact on ppm, function, valve durability, and lifetime management. And it behooves and it brings home the point of the need for annular enlargement procedure during SAVR, because otherwise TAVR is superior to SAVR in small annuli. Supraortic valves seem to have better valve performance, lower gradients and lower ppm, and perhaps better durability. Individual patient anatomy should otherwise guide valve selection. Importantly, is it the time for us to start thinking about a new definition of what is a small annuli among Asians? Thank you.
Thank you, Dr. Poses, for sharing your clinical experience and approach to these kind of patients with small aortic annuli, both with a native TAVI and TAVI in SAV case. And also finally raising potentially we need new definition for the defining the small aortic annulus for Asian populations. Really appreciate it. So why not, Jimmy, please share your case, and then we will discuss based on both two talks.
Thank you very much, Yohei. And thank you for staying around here. I know we are between you and your beer, so we'll be fast. Thank you very much for having me at this important session. My name is Jimmy Horn. I'm a cardiac surgeon from Singapore. So I'd like to share two cases. One of them is an FX case, and another one is an FX Plus case. So these are our early experiences in Singapore. We've only had FX Plus only last month, and FX we had it for 1 year. These are all very contemporary cases. These are my conflict of interest declaration. So first case is a 90-year-old gentleman presented with shortness of breath on exertion, the usual kind of cardiovascular risk factors, diabetes, cholesterol, hypertension. He was diagnosed as having severe aortic stenosis, mean gradient of 74. He's got a preserved EF. He's got some CKD with creatinine 130. Otherwise, hemoglobin is normal. He received PCI 8 days before his TAVI procedure. So this was how his LAD looked like, and this is how it looked like after the PCI. He's got a block right, and he's got no symptoms from it. 90-year-old man, we left it alone. Pre-op ECG, nothing really too exciting. Sinus rhythm, some left heart strain pattern. Pre-TAVI echo, mean gradient of 80, so it's probably severe aortic stenosis. Detailed CT analysis showed that his annular area is 388, so it's a small annular case, perimeter just under 71 millimeter. His LVOT is about the same size as his annulus. SOV dimension about 27 to 28, so adequate space, quite capacious. STJ is not calcified and it's about 26.7 millimeter. In terms of coronary height, it's 13.3 on the left and 20.6 on the right. STJ height around about 20 on average. So based on the IFU with this sort of parameters, suitable for a 26 millimeter FX Evolut valve. So another thing we saw from the CT is that he's got very tortuous aorta. Extremely, and this picture on the right-hand side does show the pictures of how tortuous the descending aorta is. And nevertheless, we got a balloon up. We did a 18 millimeter pre-dilatation with a pneumat balloon. That went fairly uneventfully. And we got the device up the descending aorta. So watch, for those of you who have used the new FX device, see how flexible this is. The newly improved longer, softer nose cone just bends with a curve. And in fact, even the valve stand does do a bit of bending as well when you cross the very tortuous area. And this is how it crossed the aortic arch. So that all went fairly straightforward. So we started deploying the valve. Initially it was a bit deep. We pulled it back to get to our target zone of 3 millimeters. So those 3 dots told us exactly where we need to be. This is our check angiogram. We're pretty happy with the position. And we deployed it. So unfortunately, I don't have the post-dilatation fluoroscopy. We didn't save it, but we post-dil with a 20 millimeter pneumat balloon, and this were the post-op echo, mean gradient of 9.6, and trivial paravalvular aortic regurgitation. ECG was absolutely fine, still in sinus rhythm, not much changes there. So that's our first case. So we're pretty happy with this 90-year-old man's results. Second case is a 70-year-old lady. 9 years ago had the St. Jude's trifecta 21 millimeter valve implanted. She was okay until 2 years ago, was diagnosed as, during the follow-up, diagnosed as having severe aortic stenosis, but she was asymptomatic for the last 2 years. The last 3 to 4 months developed NYHA class 2 symptoms, and now she needs a hip replacement. So no surgeon was willing to touch this patient until her aortic stenosis was treated. So that's why she was referred to me by my surgical colleague, another one of my surgical colleagues. So I'm actually a second surgical consultation. She vehemently refused redo operation. The first operation done by another surgeon, and she had a pretty turbulent recovery time, so she absolutely did not want surgery. Her coronaries were normal. Her hemoglobin and kidney function normal. So on paper, she's a low-risk redo case, but unfortunately, she just refused. So she came to see me as a second surgical opinion. Of course, we tried to talk her into surgery. She just would not have it. So she was referred to me for valve-in-valve consideration. This is her echo, EF of 65, mean gradient of 51.7, AVA 0.85, continuing equation. ECG has a pre-existing RBBB pattern. So CT analysis showed the internal diameter is around about 18 millimeter with an area of 255, another small annular. So she's only a 21 millimeter trifecta, so you expect that. Perimeter is about 56.7. Again, LVOT is very similar to the annular measurements. SOV-wise is about 31 to 32, and STJ is quite spacious, 29.8, and not calcified. Now, looking at the rest of the aorta, ascending aorta high up from the annulus, looking at the VTC and VTA, the distance were good. VTC is at least 5 or 6 millimeter using a 21 mm circle, and VTA is at least 4 millimeter. So we're happy to proceed. And in fact, if you look at the pictures, the coronary appears after the leaflet disappears. So we're quite happy that probably the leaflet height is lower than the wrist plane is lower than the coronary plane. So coronary height-wise is 13.4 on both sides. SCJ averaging about 20, 19 to 20, but it's a very, very horizontal aorta, angle of 76 degrees. So based on those measurements, we proceeded with a Evolut FX 23 millimeter valve. So this is the coplanar view and near cast overlap view. See how horizontal the aorta is. So we did a pre-dilatation of using an 18 millimeter pneumat, and that went uneventfully. We started to deploy, and the check angiogram showed that we are pretty much at where we want to be, 3 millimeter with three dots at 3 millimeter. And this was our final release. So everything went fairly smoothly. And this is our aortic root angiogram after correcting the parallax error. We are probably about 4 to 5 millimeter implant depth. We post-dilated it with a 20, because of valve constraint, we post-dilated it with a 20 millimeter true balloon at 6 atmosphere. 6 was the burst pressure, so we just stopped at 6. Final aortic root angiogram. So this is the post-DIL. And the final aortic root angiogram was pretty satisfactory, no paravalvular leak at all. And this was a day 1 post-op transthoracic echo, EF is preserved, mean gradient of 15. So with some small surgical valve, you would get that kind of gradient. So we are pretty surprised and pretty happy with this sort of gradient for a valve-in-valve. No aortic regurgitation, and ECG no change, still a RBBB pattern. So in conclusion, the Evolut TAVI system is safe and effective in treating patients with small annuli. Future risks with coronary access and TAF procedure can be managed with very careful pre-operative CT analysis to determine your implant depth especially. And this Evolut system is effective in mitigating some of the hemodynamic issues associated with small annuli, in particularly the valve-in-valve cases, the small surgical valve cases. This Evolut platform does mitigate some of those hemodynamic concerns and allow some patients to avoid relatively higher risk redo operation. With that, thank you very much.
Oh, thank you, Jimmy. So after appreciating these two, I would say representative cases from Dr. Posas and Jimmy, can we ask Man? Any feedbacks, comments for these typical cases, and how are you approaching these small aortic annuli cases in your practice?
Yeah, in our database, for type people, the average aortic annulus is about 440. So I think majority of them would fit into SMART trials. But our body surface area is roughly about 1.5, a little bigger than the Japanese colleagues, patients, but not as big as the Western community. I think I agree that we might want to think of the new definition for Asians, and that would be helpful. I think having the low gradient is a good thing, as long as it doesn't compromise other things. For very, very small annuli, I think if individualized patient, I think self-expandable supraannular design is a good option for the patient, certainly.
Thank you so much. Carl, any additional comments from your side?
Thanks, Yohei. Look, I agree with everything Man said. It's interesting when I look at in Australia, for example, obviously it's more Western population. You know, we're still multicultural. Certainly the Asian population within Australia, the annuli is smaller, and on top of that, there's a higher proportion of bicuspid valve as well. Mm-hmm. So I think this will allow us to achieve a lower echo-derived gradient. Yep.
Thanks, Carl. Kintaro?
We have a question from Dr. Miho Fukui. She asked that for younger patients with small annuli who is expected second intervention, what valve type should we choose for index TAVR or TAVR?
Very insightful questions. Thank you, Miho. So who would like to address this question?
So the question was, the specific question was,
Oh, Kentaro, could you?
No,
or
one more.
can you repeat that again?
Go ahead. Yeah.
Can you repeat it?
You mean the question?
Yes, please.
So for younger patients with small annuli who is expected second intervention, what BAP type should we choose for the index TAVR or TAVR?
The question that we got to start with the definition of what is young, no? Because in general, if we have any individual less than 65 with a small annuli, we have a close discussion with the surgeons with regards to annular enlargement. So our first priority in younger individuals is to try and shift them to surgery as much as possible. That not being possible, then you need to start looking at the coronary heights. If the coronary heights and the SOVs are very wide and the coronary heights are relatively high, then you may start considering supraannular devices, primarily because of potential durability and lower gradients and lower velocities. On the other hand, that leads you to the question of what about coronary access in the future? So it has got to be a device that will allow you to access the coronaries in the future. And if that valve fails, then what is the next option? Especially if the coronary heights are low. Once again, this is issues that we discuss carefully with the surgeons, and we push really hard for them to consider the option of annular enlargement.
Thank you. So we need to consider the optimal hemodynamics, but at the same time, the repeatability of the potential second valve intervention. Yeah, thank you so much.
One more question from the audience. They had to choose the size of the ballooning for fracturing old surgical prosthesis.
So maybe Carl.
Thanks, Yohei. The short answer is that you look at the Vinipapat app, and that tells you, but usually it needs to be larger than the internal diameter of the surgical valve, obviously. So the surgical labeling is a good start, but the app actually tells you quite nicely between different valve types.
Thanks, Carl. Yeah.
If I may add from the first question, I think young is one thing, but I think life expectancy on that particular patient compared to durability. So I think that's come to the point where a CT scan evaluation for younger patients before deciding what is the good option of treatment, whether surgical or a TAVI, and if TAVI, what kind of valve. I mean, by all means, if we put an Evolut in and there's a chance of redo-TAVI in TAV, I think that might be the best option for younger patients. But I think we only need more information before we make a decent decision. Otherwise, we can be guessing.
Exactly. Thank you so much for all the insightful comments. I think for the sake of time, we have to move on to the next section.
Okay.
Kentaro?
Yep. So thank you very much, Yohei. So now we understand that the robust data of the SMART trial for the patient with small annuli. So we also have the something to learn how to cannulate the coronary guiding catheter after implantation of the Evolut valve. So could you please raise your hands if you have some difficulties in case of the coronary guiding catheter cannulation after Evolut TAVI valve? Okay, some of them or some of you may have some problem. So it's good reason to stay in this room. So I'd like to introduce the first speaker, Yohei. So you're going to talk about the cannulate TAVR study.
Okay. Thank you, Kentaro. Thank you, Kentaro. I would like to briefly share our initial experience about cannulating coronaries after TAVI implantation. So this is my disclosure. So why did we do this study? So we know that commissural alignment facilitates coronary access post-TAVI. This new Evolut FX valve has shown improved commissural alignment compared to the previous iteration, Evolut Pro, Pro Plus, because of the three markers which is located at the commissure. And previous study with CT scan post-TAVI has shown high rates of commissural alignment achieved based on the golden markers on fluoroscopy. On the same study, coronary alignment was less frequently observed. So in this study, the aim was to investigate the ability of performing coronary cannulation, which is sometimes considered quite difficult post-TAVI with Evolut FX, with gold markers aligned with cusp overlap view. So to assess the impact of commissural and coronary alignment, all patients underwent post-procedural CT scan, and we investigated the feasibility of coronary cannulation. So this cannulate TAVR extended study was a multi-center study with US, Japan, an investigator-initiated and prospective study. We collected consecutive patients with severe AS who underwent transfemoral TAVI with Evolut FX implant in the contemporary fashion using cusp overlap view. We know that if we align the valve properly with this cusp overlap view, one marker which comes in the commissural of left and right coronary cusp, and two on the other side. And coronary angio was performed immediately after TAVI and CT scan afterwards. So this is a summary of our study. So we had 126 patients from both centers. Average age was 81. So the definition of successful cannulation for both left and right was if we were able to cannulate within 10 minutes. We just follow the definition from the previous literature. And for the left, we were able to cannulate all cases, either selectively or semi-selectively. But for the right, the success rate was a little bit lower as anticipated. And post-procedure CT scan showed that majority of patients using this FX system had achieved coronary commissural alignment, and also high rates of coronary alignment, but still a little bit low coronary alignment rate. So how did this coronary alignment impact the time for coronary cannulation? If we had misaligned coronary arteries, either left or right, the cannulation time obviously took longer, significantly longer time. And we were able to identify some anatomical factors which was associated with suboptimal coronary cannulation, which was defined that it took longer cannulation time and semi-selective cannulation. So for the left, if the patient had low coronary height, it was had a trend to have a suboptimal cannulation. And if the patient had coronary misalignment, it also had impact. And for the right, shallower and we can say narrower sinus of Valsalva was associated, and also the coronary misalignment. So to summarize my talk with this slide, this study was the first to investigate coronary cannulation after Evolut FX with dedicated post-procedure CT scan. High rates of coronary cannulation was achieved with both commissural and coronary alignment post-TAVI. And coronary misalignment was identified as the strongest predictor for both left and right coronary cannulation after this procedure. Thank you so much for your attention.
So thank you very much, Yohei. Your data is so encouraging. Even though the case with the coronary misalignment, we can still engage the coronary. But we also need to be experienced, so we need to learn from you a lot. So I'd like to introduce the next speaker, Dr. Balbir Singh from India. And he's going to share his experience for the coronary cannulation.
Thank you very much for having me here. So can I? So most of us think that coronary access post-TAVR is harder. But I think that has been overblown. And particularly when we talk of coronary access, we think large frames are going to give a harder time. But if we do things properly, we will achieve much higher success, as has been just presented. So this topic has been clearly overblown. But the fact remains that Post-TAVR, 10% will develop ACS and 2.3% will have a STEMI. So we need to understand how quickly to cannulate even in large frames. And this can be done very easily and very quickly. So if we look at the TAVI data, which is in the intermediate risk patients, 2.3% within 25 months of a TAVR valve will need an angioplasty. Having known this, we must all know how to cannulate coronaries. The first principle is that we have to get through the cells. So we cannot get by the side of the catheter. So we make sure that the wire goes in very easily, and we have to get through the cells of this catheter. So some simple tips: Judkins right, Judkins left. Downsize the catheter by 0.5. The reason is that this is a different aorta now. You have a smaller waist, so your catheter has to be smaller. So if you take a longer curve, it will not hit it. Aim for the waist of this evolute and go coaxially. You may have to go through different cells to finish it. Use of guide extension catheter should be liberal, and always remove the catheter with the guide wire in rather than to just pull it, because you might just pull the valve, some of the cells, and pull the valve upwards. So these are some very basic simple principles. Right coronary catheter can give problems. It's not because the valve has made some difficult things. It is because the right coronary has a different origin, sometimes upwards, sometimes posterior. So that makes it sometimes difficult. So left is easy, right can make it difficult. Just put an aortic catheter to do aortogram, and you will know where exactly that right coronary is, and you will be able to hook it. One thing one must always remember is the valve geometry. So if you see this C post, it is towards the commissural post. So this C mark tells you where exactly the valve is. The second thing is the skirt is always fixed 13 millimeter. So you need to be a little down to prevent the skirt hitting the coronaries, because if your skirt hits the coronary, the perfusion may be maintained because of the SOVs, but when you hook that coronary artery, you'll be in trouble. So if you have a lower coronary height, make sure the skirt is below the coronary. So that is the second important thing that you must know. The third important thing is that the C-tap is at 90 degrees of the height marker. So height marker is your friend to guide you where the C-tap is going to be. So this is an animation from Gilbert Tang showing that if you use this hat marker on the outer curve and get in the coplanar view with the hat marker on the outer curve, and when you go to this hat marker on the outer curve, and when you go to the commissural overlap view, which is the hat marker will be in the center, it will be facing you. So these are very simple tips which make commissural alignment very easy and make the post away from the coronary. So when you have the post away from the coronary, it is easier to access this. So this example of CT showing a commissural post which is away, and this you have a lot of room for the coronaries to be hooked. So surgeons always do commissural alignment 100% of the times, and no commissural post is against a coronary. So this, we have to replicate this with our designs, and this can be done. And this may or may not impact long-term durability. This was a paper from Mount Sinai, which shows that if you use an FX valve, using hat marker as your guide, you will achieve a commissural alignment. This was CT guided, checking whether it was commissural alignment or not. With FX, you could achieve it in 93%, just using head marker. With Evolut Pro in 80%. So FX affords that comfort of using hat marker and those two arrows and the two dots to help you. So commissural alignment will give you better coronary access, may also have a better hemodynamics in the long term. Simple, put the flush port on 3 o'clock, your hat marker will be on the outer side, and just follow that hat marker towards the end. How do you engage the catheter or the guiding catheter? Go to the LA projection, remove the parallax. Your C port, if it is anterior to the outer curve, the inner curve, you know the commissural alignment has been done. If it hasn't been done, you will have some trouble getting into that coronary. So if the commissural alignment is good, you will have no problems. Get in, always consider doing an aortogram if you have a difficult access. But in STEMI, you want to go in. Use the neosinus to get the guide wire in. First, get the guide wire into a neosinus, push your guiding or a Judkin catheter, pull the wire, it will just automatically hook. It happens within seconds that it happens. Don't try to come from downwards upwards. This is a natural tendency when we hook the guiding catheter, like an EBU catheter, we always go down and then come up. So in the native valve this works, but in an evolute this may cause a problem. So you try to get coaxial. And accessing the right is also generally simple, but sometimes can give a challenge. Let's look at a case. This was a case which was done in 2021. So we have been very careful with the hat marker. This patient has a mechanical mitral valve. So the hat marker is in the center. This is a commissural overlap view. Two commissures, right and left, have been overlapped. So we have the hat marker right in the center, which is absolutely perfect. Once the valve is deployed, you see the C port of this patient is just anterior to the curve, and the coronaries are perfusing well. This patient developed an ACS a year later, and see how the left catheter has gone and hooked so easily into this valve frame, and so was the right. So this right has a tight lesion. You can see this tight lesion. And we have actually been able to use no guide liner, got the guiding in, did an imaging guided PCI, and this is the final result. So if initial steps were taken right, you will have no problems. What about radial access? So the left radial is as good as a femoral access in most of these patients. So if you want to go for a radial access, choose the left radial access. Thank you very much for your patience.
So thank you very much, Dr. Singh, for sharing your best experience. So we really understand the importance of the commissural alignments. And for the sake of time, we would like to introduce the third speaker, Dr. Kent So from Hong Kong. So recently, they have studied the FX Plus with window. So he's going to talk about window into the future. So if you're ready.
Yep. Thank you, Kentao. So this is Kent. I want to share with you our experience, sort of like initial experience with the FX Plus platform. So here's my disclosure. So I don't want to repeat this. We know coronary artery disease in TAVI population is a common problem. In some of the cohorts, 80% of cases actually has significant coronary artery disease. And when we are facing younger and lower surgical risk patients, this problem is becoming very important. As previous speakers has mentioned, tackling coronary access in the older generation requires some sort of techniques because if you see from this bench test, the guiding catheters can get easily caught on the frame cells when they are very small. So you need the JY and also floating wire techniques, some of the additional techniques. So when it comes to the FX Plus platform, it actually solve some of these problems. So the FX Plus platform is built on the FX delivery system together with an FX Plus valve that has a 4 times larger windows to enable the future coronary access. This is important to be accompanied with commercial alignment, as previous speaker has mentioned. So the 3 o'clock flush port location is important, and together with another additional check to check the head marker orientation, which we have to make sure is on the outer curve when we get across the aortic arch in LAO projection. So with these 2 maneuvers, you'll be able to achieve a favorable commercial alignment, which means doesn't mean a perfect commercial alignment, but at least it's a favorable commercial alignment in 96% of the cases. So with this is actually very important to allow a future coronary access. So this is one of the case report that's published in JACC case report last year. So in one of the early experience in US, you can see from this CT with a perfect commercial alignment, you can see this window is the one that allows you for future coronary access, and is significantly bigger than the cells that's surrounding it. So with commercial alignment, the future coronary access will be much easier, as illustrated in this case. So I'm going to illustrate with one of the case example of the implantation of the FX Plus platform. So our patient is 77-year-old with hypertension, DM, and also atrial fibrillation on apixaban. She has a bioprosthetic valve for a bicuspid AS back to 10 years ago using a trifecta 19 millimeter, which is common in Asian population. Small valve is implanted. She unfortunately has progressive worsening of the mean aortic valve gradient and also has a dropping of the LVEF to 28% when she was referred to us. The mean aortic valve gradient is still 43. At the same time, she also has a mid-LA dilation. And our heart team concluded that she is surgically inoperable and recommended for valve-in-valve TAVI. So I didn't include a CT because it's actually quite a straightforward case. The coronary height for both left and right are more than 10 millimeter, and the VTC distance, because the patient's native is bicuspid, the VTC distance were actually well above 5 millimeters. So there's no concern on the coronary height. So this is a mid-LA dilation. We actually do the concomitant PCI for this patient because it's actually relatively straightforward to put in a stent and to tackle the LA deletion. So this is the FX Plus platform. So the implantation is actually completely the same as the FX platform. You can see there a free radio-opaque marker. So we start using the trifecta valve as a landmark and use these free radio-opaque markers for reference to implant for the implant depth. So the first implantation was a little bit low. So that's why we actually decide to recapture it. So this you can see is a bit low. So we actually tried a few times. So this is actually the sternal wire. So when I look at this image, it looks like the valve is not stable, but actually this is actually the sternal wire. The epicardial lead wire that was cut after surgery. So in fact, the valve was actually quite stable. So we think this position is actually quite optimal. So we then fully deployed the valve. The implant depth was actually quite nice, around 3 millimeter to 5 millimeter in different level. And because this is a trifecta valve, we are not able to fracture it, but we will be able to modify the upper crown. So we actually use an 80 millimeter true dilatation balloon, and then to sort of stretch the upper crown and hopefully to improve the hemodynamic. And you can see actually the upper crown sort of like expand a little bit. So with this maneuver, we were able to improve the hemodynamic. So, and in some of the projections, for example, in this is sort of like close to the coplanar view, you'll be able to see this diamond. This diamond, you can see there's no metal frame here. This is actually one of the window that actually overlapped from the other side. So this is the RCA entry, and there will be another window of diamond at the back, which overlap together at this projection for the non-coronary cuts, and the left coronary cuts is actually not well seen here. So this is the windows for the future coronary access. So for this patient, the valve is actually very well expanded, and the mean gradient is only 7. A little bit surprised to us because usually we see around 10 even with the stretching, but this patient actually is quite good. So this is our initial FX Plus experience. It was actually first launched in late September in last year in Hong Kong. And our center till December has a total 16 cases of experience. 14 cases were actually done transfemorally, and 2 were percutaneous axillary, and 1 valve-in-valve, and 2 cases combined with PTMC because of rheumatic in nature. And around half of them are actually done under local, and 9 of them under monitor anesthetic care or general anesthesia. All of them has less than mild or equal to mild paravalvulic. And so far, we're fortunate, none of the cases so far required a PCI coronary angiogram. So to conclude, the FX Plus offer a window into the future coronary access, and the window maintained the strength of the self-expanding valve platform while we solve its weakness of future coronary access. So this is just a 3-second capture that we did for this presentation. We did last Tuesday before I came to Tokyo Valve. This is one of the cannulation of the left side. You can see very rapid, just 3 seconds, you'll be able to get the diagnostic catheter inside. Thank you very much.
So thank you very much, Kent, for your fantastic example of your experience with FX Plus. And I'm very happy to see that with the very good commissural alignment, you can achieve very good coronary access, especially with FX Plus. So Kent, I would like to ask a question to you, Kent. So do you think the new window gives you much more forgiving coronary access?
Yes, I do think so. So although we don't have cases of requiring PCI after the FX plus, but from that case example, in fact, you don't have to struggle a lot because there's no metal in front of the coronary, but the commercial alignment is essential.
Yep. I hope that this new device will make our life much easier. So thank you so much for a fantastic lecture. And we already covered small annulus and coronary access. The last but not least, we also have the very big topic of the TAVI in TAV. I would like to hand over to Yohei to cover this topic.
Thank you, Kentaro. So, the indication of TAVI is expanding little by little to lower risk and younger patients. So, man, you're the man who will give this topic.
All right.
All right.
Okay. Thank you. Thanks for having me. My talk will be on prioritizing lifetime management, but because of the interest of time, I will focus on TAV in TAV. So the patient lifetime, as we know, I think it's very important to optimize the index procedure, make sure that it had good durability or valve longevity, maintain coronary access. I think we have gone through that. And I think one of other things that is important is the solutions if the index TAVI fail, or another word, repeatability. And if so, if not, then TAVI explant is an option. I'm just going to focus just on that because of the time. When comparing between repeat TAVR and TAVI explant, we found that the repeat TAVI, if possible, or if it can be done, it had lower 30-day mortality, 6.2 versus 12.3, and lower 30-day MACE. This is from the US data. Also, very importantly, to get some data from this study from Gilbert. It's the explant or redo-TAVI international registry of about 30 centers. It's not randomized, it's a pair centers in about 400 cases. They found that the mechanism of TAVI failure, this is not a bailout, that the SVD is a majority of the case. And what I found interesting was the time to reintervention. One of these is that the one that fails, it doesn't last very long, and also they also do landmark analysis showing that even though the TAVI explant had immediate higher mortality as compared to redo-TAVR, but once they do landmark analysis, the curve continue to be the same. So at least reconfirm that even though we had an immediate success, in the long run, it doesn't compromise at least intermediate term success. So I think that's quite important. So I think they come up with this algorithm that if you had structural valve deterioration, if redo-TAVI feasible, if it is, then redo-TAVR should be the first priority. If not, then TAVI explant. Also another group that TAVI explant might be more suitable is that if the patient already had PPM or PPM as the cause of valve failure. One other thing that also the data suggests that when you use your second valve as a balloon or self-expandable, so in black is the second valve is the balloon, and the purple is if the self is the second valve. There's no major difference in terms of success or safety, at least in the short term. But in terms of residual gradient, you can see that if your second valve is self-expandable, the gradient is significantly lower as compared to balloon expandable. And I'll just skip that. I'm just going to share you the case that we have. It's an 82-year-old woman, BSA of 1.4, underwent first TAVR at the age of 74, used S3 number 20, and now presented with new onset heart failure. The echo confirms that it's prosthetic failure due to severe TAVI stenosis, EOAI of 0.4, mean gradient of 61, DVI of 0.24, so all the parameters. We also had the original CT. It's a very small annulus, 287, perimeter of 62, and this is the SOV-STJ, and the coronary height is somewhat low. We did implant the S3 nominal volume number 20, immediate post, the mean gradient was 13, and but during the follow-up, you can see that with the balloon expandable with a small gradient, the echo gradient remain usually quite high. This is quite high, but the DVI and EOAI seems quite okay. The leaflet was normal, so there's some degree of patient prosthetic mismatch from the beginning. However, at year 7, you can see the mean gradient increased and DVI dropped to below 0.25, and EOAI is certainly a problem, 0.41, and also the echo show limited leaflet excursion and calcification and so on. We also do a complete invasive mean gradient of 63, so confirm that this is a real high gradient of the device. So with the evaluations of the original TAVR, it's a 20 mm, and as a common theme, when you look at these, it's quite often that the first TAVI is not fully expanded. The average area of about 19. This is the evaluation of the aort. Core height is somewhat low. STJ is big, which is good, so that we will be safe to put in another TAVR, more or less. So for this case, we decided to do the Evolut in the SAPIEN. When we put an Evolut in the SAPIEN, there will not be a index TAVI expansion because of the strength of the Evolut is less than the SAPIEN. It's vice versa, another way around. So again, with careful evaluation in different levels of the SAPIEN, and the average area about 241 in the middle and about 280 in the inflow and the outflow. VTC is not a problem. VT-STJ is more than adequate. So this one, we can do both. So basically, the same algorithm, neo-risk plane, below coronary risk plane, no. If is neo-skirt below STJ, yes, but VTC more than 4. So it should not be a problem. When we do these coronary alignment or commissural alignment remains important. Landing zone for the Evolut in SAPIEN would be the area here from node 0 to node 1. However, if the S3 is at level 0 or above, like very high, then you can consider put a Evolut a little lower. So this is the intent landing zone. So I'd just do coronary protection just for the sake of it, but actually you don't need it. So slow deployment and make sure it's commissural allied. This is the cast overlap view, so commissural C-tab is in the inner curve. And post-dilatation with the 20 mm balloon, and we had the invasive gradient of 14 of the Evolut 23 in the SAPIEN 20. We have a good commissural allied, but with these we will have a taller wrist plane and a similar neo-skirt. So I just want to conclude that when the first TAVI fails, the second TAVI, the Evolut platform is also a viable option for TAV and TAV. When the potential advantage is the low gradient and also reduce the risk of PPM and yeah. Okay, thank you.
Thank you, Man, so for highlighting the advantage of the superannular platform with a small index TAVI platform. So Asians have small aortic roots, so as for TAV and TAV, there's a risk of coronary obstruction. So I think Carl will mention about that in his talk regarding the leaflet modification. So Carl, please.
Thanks, Yohei. So even for a valve that has long durability data, we know that TAV in TAV is coming, and it's been predicted to be the highest, fastest growing entity, both particularly in the US and the modeling. So what's different about TAV and TAV? we can do TAV and TAV if the anatomy is quite suitable, whether it's the index valve of balloon expandable or the index valve being a self-expanding. There was an Evolut large valve here that we put an Edwards within that and had to post-dilate quite aggressively. But the coronary obstruction is the main issue, as we have heard quite a few times tonight already. This is particularly an issue perhaps for supraannular tall valves, and we need strategies to address that and prevent that. And I found this from the Ocean TAVI registry, in particular in Asian population, because of a small sinus and small root. The risk of coronary obstruction from sinus secretion is in fact higher than a comparable population in the Western population. So I give credit to Dr. Dale Murdoch, who's also in the audience. We did the first basilica in an accurate that we subsequently treated with a balloon expandable valve. So as it turned out, we weren't sure when we did it that it was the first in the world, but that was first in human back in 2018 or 19. So it can be done, but it's to demonstrate the concept of basilica. I focus mainly on surgical valves. So I think many would be aware of the techniques. Some have practiced this, but this is a snapshot of what you need. A donor guide, we preferred a shortened guide with a pigtail within that, and a fine cross and a crossing wire that's an Astado wire, and the receiving side, a snare, as you can see there, and a stabilization wire. So we learned the hard way the traditional method, particularly a longer guiding catheter such as AL2 or 3 as originally recommended. The wire is so stiff it tends to slide down and often down and out. So this is what my mentor back home came up with a pigtail where you can have infinite point of attack and ensure coaxiality. And this is just another example of crossing with good contact without sliding down. So we also, the second tip that we've learned is that we tend to use a balloon to augment or assist the hole that you create. We find that this will generally give you some extra assurance to ensure the hole is bigger rather than just a slit. And this is particularly important and in fact recommended in TAV and TAV because the leaflets are quite long and just cutting it is not enough to create a V. This is like a mini unicorn from our colleagues Eric Chen and Simon Lam in Hong Kong, who created the unicorn approach. So this is the balloon-assisted laceration compared to conventional basilica, some benefit. So the next step after you have ballooned or snared, then it's creating a flying V, the rest of the steps that you're well aware of. I think when I proctor, I often get asked, do they tolerate it? Most of the time they do. The only case I've ever had was an impaired LVEF with a left main stenosis, so he got quite sick and we had to put a valve in quickly. For TAV in TAV basilica is only ever possible if you have commissure alignment. If you have a commissure tab in front of the coronary, whatever valve, whether it's balloon expandable or self-expanding, that's not possible. There's plenty of cases that we have sent for explant because the commissure tab is right in front of a coronary. So to have commissure alignment for your valve, it's very important. And then that echoes everything that we've learned from cannulate today as well. This accurate valve was somewhat commissurely aligned, but certainly not impossible. But we acknowledge that this is a picture from Dale where the guide was engaged, the guiding catheter was engaged, we pulled back and then used TOE guidance to try to asymmetrically basilica. Probably helpful. I think in those days, as we now know, there's potentially a gap there that would help, but I think this is a good example from Gilbert Tang where if you don't have commissure alignment, there's really no strategy, at least that we're aware of, that's commercially available, not even shortcut. So I think TAV in TAV presents unique challenges and maybe even opportunities for those smart ones who can design a device. Basilica for redo may mitigate the risk for coronary obstruction, but only possible if you have commissural alignment. This is why it's so important, whether it's a short or long valve. So commissural alignment for your valve now, as we have learned today, everyone practices the same. Thank you.
Thank you, Carl. Thank you, Carl. So in order to achieve leaflet modification, so he emphasized how important the index procedure to achieve commissural alignment. So is there any burning questions, comments regarding Carl and Man's talk? So one question, quick question to Carl. So you have a huge experience in Basilica. So what is the difference between the native TAVI and the TAV in TAV? Well, native TAV or TAV in SAV and the TAV in TAV for leaflet modification?
I think I perhaps trivialize how difficult it is to do TAV in TAV Basilica because the leaflets are longer, and it's been postulated quite a bit that even Basilica may not work. A leaflet that's double the length of a surgical valve, your cut becomes more parallel than a V or even bigger. So it's almost mandatory to have balloon-assisted Basilica. But on top of that, your puncture point has to be a lot more accurate because even with a balloon, let's say a 5 millimeter balloon, you have 5 millimeter against a 5 millimeter left main, for example. You don't have much margin of error.
Exactly.
So it's certainly not foolproof. For surgical Basilica, I don't usually have a stent in there if I'm reasonably comfortable. But for a TAV in TAV Basilica, I think a stent may be necessary as a fail-safe mechanism.
Thank you so much. We learned so much from you. Any special comments, feedback from our panels? I think we had a very nice discussion. So Kentaro, maybe for time to summarize this session.
Sure.
So we started from talking about the SMART trial. We're expecting, I think, 2 years follow-up data at some point this year, which is very exciting. We talked about corner access, the advantages of Evolut FX and newer iteration Evolut FX Plus that facilitates the corner access even more. And then finally, as for the lifetime management, we talked about the potential TAV in TAV leaflet modification that will facilitate the safer procedure. Thank you so much for joining. And Kentaro, I would like to have some final words from your side.
Okay, thank you very much for joining the session until the end of the day. So, so we really learned a lot for the device, new device, especially for FX Plus, which deliver us the much better daily practice. I think that tailoring our therapy to each patient is quite important to improve the clinical outcome of each patient. And from tomorrow, so we're going to have the live demonstration and hands-on session, symposium, a late-breaking clinical trial, a lot of education session. So please enjoy a lot for this year, and let's celebrate together the 10th anniversary for this meeting. Thank you so much for joining us.